I am head of the Department of Simulation Clinical Skills Training. My name is Salif Alisher Urokovich. Today's our topic is ECG interpretation. There are 10 steps of ECG interpretation. First one is evaluation of voltage calibration and record speed. Next one, determining the source of rhythm and regularity of heart contractions. Next one, determining the number of heartbeats. Determination of the electrical axis of heart. Conduction assessment. Q-wave assessment, ST segment and T-wave assessment, Q2 interval assessment of the presence of pathological changes, and last one is conclusion. Assessment of the voltage calibration and record speed. Usually we record calibration with 10 milliwatt. If you look to this picture, these 10 millimeters are high. These 20, if sometimes necessary, we can increase the amplitude waves to 2 times. Sometimes we can decrease 2 times, it will be 5 milliwatt. And we have to pay attention to speed of registration. Here we can see these 25 millimeter second, and sometimes we can register with 50 millimeter second. Next one, determining the source of rhythm and regularity of heart contractions. Normal sinus node produces impulses, but sometimes in pathological situations, impulse can produce atrium, middle part of atrium, down part of atrium, sometimes AV node. AV node has 3 parts: up part, middle part and down part. And all parts can produce impulses, and sometimes can happen that ventricle also can produce impulses, and there are ECG signs of these ectopic rhythms. First one, normal sinus rhythm. We can see P wave and P positive. P should be positive in first lead, second lead, AVF, V from V2 until V6, P should be positive before QRS complex. This P wave. We can say this sinus rhythm. Sometimes can happen impulse can be produced from down part of atrium and from upper part of AV node. In this case, P should be negative before complex QRS. And here also we can see negative P waves. This means rhythm from AV node, from upper part of AV node, or from down part of atrium. Next rhythm from middle part of AV node, we can see here P not visible, and only we can see QRST complex. And this picture also P not visible. This means here rhythm from AV node, and only we can see QRST waves. Next rhythm from down part of AV node. Here we can see negative P after normal QRS complex, and P negative. Next one, atrial fibrillation. Atrial fibrillation here, P not visible instead of P. We can see different sizes and shape, waves, and the next sense of atrial fibrillation is distance different. This also atrial fibrillation picture. Here also P not visible, no P, and RR distance different. Next one, atrial flutter. Here we can see instead of P, F waves. 2, 1, 2. 2 F waves and 1 QRS complex. 2 F waves and 1 QRS complex. But sometimes can be 3 of F waves, 1 QRS complex, and sometimes maybe 4 F waves and 1 QRS complexes. This is paroxysmal tachycardia from AV node. Here P not visible. This is T QRS complex, and this is T P not visible. This is also paroxysmal tachycardia from AV node. P not visible. This is T QRS complex. T, this is QRS complex. Heart rate more than 150. Here almost 180 heartbeats per minute. But we can pay attention to shape of QRS complex. QRS complex, normal duration, normal shape, only tachycardia and absent of P waves. Atrial tachycardia, negative P we can see. This is from atrial down part of atrium or up part of AV node. QRS complex normal. Next one, atrial flutter. Here we can see 1, 2 F waves, 1, 2 F waves and 1 QRS complex. It is usually visible in V1, V2, V3, but here in this case we can see F waves in AVR. And if in atrial fibrillation RR distance different, in atrial flutter we can see RR distance same. Polytope atrial tachycardia, we say this because shape and size of P waves different, and we say this atrial tachycardia. Next one, widening of the QRS complex. If impulse produces in ventricle, we can see like this deformation of QRST complex, and we can say discordant position of ST and T to basic wave. Here basic waves are, and we can see they are discordant, and QRS complex becomes more than 0 and 12 seconds. This ventricular tachycardia we can say wide QRS complexes, and this basic wave, this is ST and T, discordant position. Next one, also paroxysmal ventricular tachycardia. Here we can see wide QRS complexes and discordant ST and T waves. Next one, torsades de pointes. Here we can see in some group of QRS complexes direction up, and after that some groups of QRS complexes direction to down. It is danger for patients, and this is danger. Arrhythmias can lead to death of patients. Ventricular fibrillation, instead of normal QRS waves we can see different sizes and shape waves, and this is also dangerous. This can lead to death of patients. Determining the regularity of heart contraction. If the RR interval differs by less than 10%, the rhythm is considered irregular. If it differs by more than 10%, it is considered irregular. Determining the number of heartbeats at an ECG recording speed of 25 mm/second, the number of light cells between RR is divided by 300. For example, if one big box between RR distance, we divide 300 to 1 and heartbeats 300. Two big boxes, we divide to 300, heartbeats 150. If three big boxes, we divide to 300, this is 100 heartbeats per minute. 475 heartbeats, 5 big boxes 60 heartbeats, 6 big boxes 50 heartbeats per minute. Determination of the electrical axis of the heart. Normal electrical axis of the heart, we can say we have to pay attention to first lead and AVF. In both, if we see basic wave R and here also R, we can say this normal electrical axis of the heart. If first lead positive wave and AVF, negative wave, basic wave negative, we can say here this is deviation of the electrical axis of the heart to the left. And last one, if in first leads basic wave is negative and post basic wave in AVF positive, we can say this is deviation of the electrical axis of the heart to the right. Next one, conduction assessment. We have to pay attention to duration, P wave, PQ interval, QRS duration. P wave, from the beginning until the end, this is duration of P wave. P wave duration may up to 0.1 second. PQ duration of the segment, this is PQ segment, this after P wave until the QRS starting, this place we say PQ segment. This segment up to 0.1 second. Next one, PQ interval duration. This is from the beginning of P wave and until the beginning of QRS complex. This can be up to 0.2 seconds. QRS duration from the beginning until the end of QRS complex. This can be up to 0.1 second. If P more than 0.1, this can be in atrial block. If PQ interval more than 0.2, this may be AV block. And QRS complex more than 0.1, this may be interventricular block. Widening of the duration of the waves and intervals. If the P wave duration is greater than 0.1 second, it indicates intra-atrial block. If the PQ interval duration is greater than 0.2 second, it indicates AV block. If the chorus complex duration is greater than 0.1 second, it indicates intraventricular block. Q-wave assessment. The Q-wave should be less than 1/4 of the R-wave normally. The Q-wave may be deep in lead AVR. If the Q-wave is greater than 1/4 of the R-waves, these may indicate a myocardial infarction. Inferior myocardial infarction, here we can see in second lead, third lead AVF pathological Q waves. These pathological Q waves means patient have myocardial infarction. Next one, pathological Q, we can see here V1, V2, V3, V4 and even V5. First lead also an AVL, we can see pathological Q waves. This means patient have myocardial infarction. And ST elevations here we can see, this means this is acute myocardial infarction. ST segment and T wave assessment. The ST segment should be on the isoline. The T wave in adults in lead is 4 second AVF from V2 until V6 should be positive. ST segment elevation occurs in acute myocardial infarctions. A negative T indicates myocardial ischemia. ST segment depression indicates ischemic injury. Here we can say first lead, AVL leads, especially V3, V4, V5, V6, we can see horizontal depression of ST segment. This means patient have ischemic injury. And here also we can see ST depression, and V6 also we can see ST depression. This is also ischemic injury. And next picture also V1, V2, V3, V4, V5 and V6 also ischemic ST depression, horizontal depression of ST segment. This means patient have ischemic injury. Next one, acute myocardial infarction. Here we can see in first lead, AV lead ST elevation. Here ST elevation and V2, V3, we can see ST elevation. And opposite in third lead AVF we can see ST depression. ST elevation, this is one symptom of myocardial infarction. Next symptom ST depression. ST depression, this means also patient have acute myocardial infarction. And here second lead, third lead, AVF lead, we can see ST elevation and we can say here acute myocardial infarction. Next one, T wave assessment. The T wave in lead is 1, 2, AVF, V2, V6. In other cases should be positive. There are a lot of cases where T wave can be negative. For example, first one, this is left ventricular hypertrophy. Here we can say negative T. Next one, digitalis intoxication. Here we can see like these negative ST in T waves. And third one, right ventricular hypertrophy. We can see in right chest leads negative T wave also. Next one, D, E, and F, myocardial ischemia. T wave in patient who have myocardial ischemia. If patient have stroke, we can see deep negative waves. And next one, post tachycardia syndrome. Here also we can see negative wave. And next one, bundle of his right bundle branch block. Left here right bundle branch block, and here left bundle branch block, and this one VPV syndrome, Wolff Parkinson White syndrome. Next one, QT interval. We can see here QT interval. QT interval, we from the beginning of QRS complex until the end of T. And here also we can see QT interval from the beginning of QRS complex until the end of the T. QT interval. The QT interval is defined as a distance from the beginning of the QRS to the end of the T wave. The QT interval includes both depolarization and repolarization of ventricles. QT decreases with an increase in heart rate. QT increases with a decrease in heart rate. Prolongation of the QT interval occurs in fatal arrhythmias. A decrease in the duration of the QT interval also occurs in rare hereditary disease and also leads to sudden death. This is formal for QT interval. These are distance between two RR in second. This is for man 0.37. This is for woman 0.40.